some work that I did in the basic science lab in with one of the genetics faculty members. So I've had quite a bit of experience with substance use disorder in pregnancy. Some of the patients that I worked with who were HIV positive were positive as a consequence of their own substance use disorder. Some of them were positive because of their partner's substance use disorder, and some of them were born positive. So I'm excited to be here this evening. I loved being at Hopkins. I loved what I did with that patient population. So I'm looking forward to today's discussion.
Thank you. And I think most of you know me, but I am Rosemary Tyrrell. I'm the director of the Office of Faculty Development, and I also hold an assistant professor rank in social medicine, population, and public health. I've been at UCR for about 9 years, and this is the fourth session of our 6-session series on teaching around substance use disorders. And tonight we're going to talk a little bit about navigating the tough stuff. And we always have to do our CME disclosure and disclose that we have no relevant conflict of interest to disclose. I also like to share our learning objectives for tonight. We hope that by the end of tonight's session, you'll have an opportunity to lead sensitive and complex conversations on substance use disorders with both empathy and professionalism, to recognize and manage learners' emotional reactions when engaging with difficult subject matter, to create structured teaching plans that encourage open dialogue with your learners, to use research-supported techniques to navigate controversial or stigmatized content, and to apply assessment methods to gauge learner reflection and processing. So I'm going to start us off with a little waterfall. And if you've not done a waterfall before, I'm going to ask you to type your answer in the chat, but not hit enter. And then we'll count down and we'll say 1, 2, 3, enter. And then everybody's answers should come in all at once. So the question is pretty broad. It's just, what's a topic you found challenging to teach? Was it controversial or it made learners uncomfortable? So go ahead and type your answer in the chat. And now I'm going to count down if everybody's ready. And I'm going to say 1, 2, 3, hit enter. Controversial topics, gender biases, teaching about racial bias, sensitive information, and again, controversial information. Yeah, there are some topics that are just inherently more challenging than others. And this is actually one of them. So I'm going to turn this back over to my colleague, Dr. Brenda Ross, and she's going to cover this next section.
Okay, very good. So we're going to talk about, I'm sorry, let me get a little bit better organized here, guys. Going a little bit ahead of myself here. About difficult scenarios in obstetrics and gynecology. So model curiosity and compassion. And we're going to open with a reflective vignette, a patient story. And we're going to talk about some of the emotions that arise. So this first vignette that we're going to explore, and we're going to, Rosemary's going to advance the slides. This is a vignette about a patient. Let's say that her name is Jasmine. She's 27 years old and about 28 weeks pregnant. She arrives in OB triage saying that she hasn't felt the baby move for the entire morning. The nurse hands you the chart with a quiet sigh, and at the top of the chart, highlighted, it says that the patient has a history of methamphetamine use disorder. A team member mutters, she's probably just looking for a place to stay. Jasmine appears anxious and says, I'm trying really hard. I check in the clinic. I go to the meetings. I just messed up. And the medical student says, you know, if she just used one time, is there definitely going to be a problem with the baby? The fetal heart tones are reassuring. You sense judgment in the room and uncertainty among the learners. You must decide how to respond, what to teach, and how to support Jasmine with dignity. So we're going to take a few minutes, or about a minute or so, and see and then come back. And we'd like to talk about what emotions come up and then go from there. So I'd like for us to take 30 seconds to a minute and then come back and discuss this vignette. So starting now, and we'll come back in a minute. Okay. So what emotions come up? Does anyone want to talk about some emotions that you sense that you felt with regard to this vignette?
I can go ahead. This is so familiar to me, and so the first word that came to me is disgust with my colleagues that made the comment about the patient and stigmatized her. Um, and it's a really great teachable moment because there's a lot that could be taught in this just one scenario, from everything from health systems to the science behind addiction, and how to take that medical student question and someone such as yourself in the MFM literature and say, hey, is one time going to do the baby in? It's a different drug, it's a stimulant. So the fetal heart tones were reassuring, that's good, even though the fetal kick count was concerning initially. So those are kind of my thoughts.
Very good. Thanks for being willing to jump in. Anybody else want to add something?
I mean, I feel a lot of the same things that Dr. Bolad is feeling, but then also torn, right? Because I feel like I want to not pay attention to what everyone else is saying so I can move into being compassionate and with the patient, right? And taking care of her and kind of frustrated that I have to sort of also simultaneously keep everybody in line, right? Because I'm trying to be compassionate with everybody, but it's you feel split, right? In
Right,
terms of your attention.
right. Any other comments?
Yes, Dr. Kendrick has a raised hand.
I often find myself in situations like this. Doesn't have to be substance use disorder, but it could be any condition.
I'm having a little bit of a hard time hearing you, Dr. Kendrick. I'm sorry.
Can you hear me now?
Yes, that's a lot better. Thank you.
Okay. So I find myself in these kind of similar scenarios. It doesn't have to be substance use disorders, but just a general scenario of people don't understand. And then there's concern for the patient. And so I like to, the way I see just like a normal scenario for me would be take care of the patient while they see me take care of the patient. And then once the patient, while I would be explaining and talking to the patient, obviously some of the things that would come out of my mouth would be educating for the people that are listening in. And then at the summary of that, once the patient left, I would then have a conversation about maybe we need to really have some discussion about understanding. Dr. Bullock was talking about the science behind substance use disorders and getting people to understand what these cycles are, and so that they can become aware of this is what disease is like. This is normal. This is sort of the process that you go through. So that's it.
Right. Right. So all of those of course, are really very relevant points. And of course, the reality of it is that frequently we do feel a sense of compassion for the patient. We understand, whether it's our own, it brings up our own emotions, whether it's addiction to food, addiction to wherever our shortcomings are as individuals, recognizing that none of us are perfect, but also recognizing that she does have a substance use disorder and there are real consequences to that. So methamphetamines are stimulants. She can erupt her placenta. She didn't this time. The fetal heart rate is reassuring, helping her to understand that getting into treatment is important. She already has demonstrated that she's making an effort, congratulating her in that effort and helping to make sure that she has access to the resources that are available to her. But certainly not further stigmatizing her is the primary thing, and being and providing trauma-informed care. Like, we recognize that this is a hard process, and we congratulate the effort, and we want to make sure that you have access to the resources that are available. So I think that that's a really healthy discussion. Anything you'd like to add, Rosemary?
No, I think what struck me also was the I'm scared that you're going to call Child Protective Services
Right.
and how you would reassure the patient of what your responsibilities are in regards to that.
Right. And so that's an important discussion. And, in my years of practicing maternal fetal medicine, I have only called the police once, and it was a completely different situation. It was a 16-year-old who was actively and by choice involved in a sexual relationship with a 40-year-old man. And I told the girl was pregnant, and her mother brought her in because she had herpes, a new onset herpes infection. And I told her, and her mother knew she was involved in this relationship. And her mother brought her into labor and delivery, actively lying to me, saying that this man who was accompanying them was the stepfather, that he was the mother's boyfriend, when in fact he was the daughter's boyfriend. And I told the mother that this is unacceptable and I'm calling the police. So I've never reported a patient who was actively involved in substance use. So yes, according to state law, California state law, obstetricians are supposed to report. It's sort of what that looks like varies according to the hospital. Of course, at UC Riverside, we don't have a hospital, so I can kind of skate on that. Social workers are usually involved, and I don't know that the social workers typically report. I know that while I was at Hopkins, we didn't report, but we had social services involved, and we tried to get them involved in programs. So, and reassuring of patients accordingly. Babies who are born and test positive typically are reported to CPS. So whether it's marijuana or other substances, CPS gets involved at that point, but then that's a pediatrics issue rather than an obstetrics issue. So
It's interesting.
yeah. So we do talk to patients about that part, and sometimes it's based on testing the baby directly, and sometimes it's based on a drug screen that's done during the pregnancy. So moving on from there, the next slide. So discussions about substance use in pregnancy and race, of course, often carry deep emotional and moral weight. The next slide. So a study that was published in 2023 by Caesar et al. Had some interesting findings. They interviewed 7 Black and Latino women in California who used cannabis during pregnancy, and we can talk a little bit about that. There's some very interesting data around that. And there were several themes that were apparent. There was a lot of fear and stigma. Participants in the study anticipated judgment and often avoided disclosing use because of fear of punishment versus hope for support. A lot of these women feared being reported to Child Protective Services, even when they disclosed using for medically indicated reasons. And so from personal experiences, patients will report that they were using because of hyperemesis. It's much more accessible than coming into the clinic and getting prescriptions for Zofran, particularly for women who don't have access to care and don't have medical insurance. It's easier to get marijuana. And they also report using for instances like depression, or they've already been prescribed medical marijuana for depression frequently. So, and they have limited support from the healthcare establishment, and they are afraid that the punitive policies that they encounter when they come in seeking healthcare will result in a delay of healthcare and an increase in child welfare involvement. So even though marijuana is legal in California and was legal in California in 2023, there is still active involvement from child welfare. And there are a lot of segments of the population where women proudly support use of marijuana in pregnancy, and, just believe that it's safer because it's quote unquote natural. And they find other women who support that and find groups who encourage that. So they get a lot of mixed information, and some of that is coming from the lack of well-performed studies from the medical community, because since marijuana has been illegal for so long and people were not disclosing that they were using, there haven't been a lot of studies. So since it's been legal and people have been more forthcoming, there are now more studies that have been started to come out. Next study, I'm sorry, kind of got off track a little bit. And my husband forgot that I'm doing a lecture, so excuse my phone, guys. There was another study that was published in 2024 where they did qualitative interviews with 23 postpartum birthing women of color who used substances during pregnancy. The participants perceived more requirements. So women of color felt like they were required to jump through more hoops than their white counterparts, that they had to go through more drug testing, that they faced more discrimination, that which consequently led to an avoidance of care, a higher burden of self-advocacy, which is something that you frequently hear, particularly African-American women complain about, that they're perceived as being angry Black women when they complain that they're in pain and that they have to fight for their care, that they're not taken seriously. And as a consequence, they don't feel as if they're being heard. And that their negative effects include inadequate postpartum pain management, pressured or biased contraceptive counseling, and greater risk, again, for CPES involvement and custody loss. So making it a point to promote trauma-involved care and trauma-involved or shared decision-making is important. Reduces bias, avoid unnecessary tox screening, and increase culturally responsive and anti-racist care. Next slide. And another survey, a study surveyed 143 Black adults receiving addiction treatment in Ohio and measured group-based medical mistrust and expectations of discrimination in care. The group-based medical mistrust scale was published initially in 2004, and it's a 12-item measure that assesses suspicion of mainstream healthcare systems and healthcare professionals and the treatment provided to individuals of the respondents' ethnic or racial group. The key findings of this particular study is that mistrust is common and linked to care delays. Higher mistrust leads to more likely delay in seeking addiction treatment due to a fear of discrimination. Patients anticipate racism, that there is personal history matters, and that the implications include Black patients experience real and anticipated racism in addiction care. Mistrust may reduce timely engagement and retention in treatment, and using tools like GBMMS can help clinicians identify mistrust, guide trauma-informed conversation, and improve equitable care. So sometimes you find just having real conversations with patients, like, I think, or it seems to me that you don't really think that I recognize, or you don't think that I understand, or that I hear what you're saying. Let's break that down a little bit. Or I feel like you don't trust what I'm saying. Can you explain that to me? Or are there ways that I can better address what you're feeling? Or just helping patients to recognize that you recognize that they don't trust you for whatever reason. Just addressing the elephant in the room, then they feel heard and seen. And so I think sometimes just bringing it to the forefront. I've had patients accuse me of things like, women have an increased risk for preeclampsia just because they have state-sponsored insurance. And so I had a patient who was Caucasian and had IEHP, and I explained to her that because she had advanced maternal age and had state-sponsored insurance, her risk for preeclampsia was increased. And she became angry and said that she felt as if I was biased against her because she had IEHP. And I tried to break that down for her. And so, it's not because I think that I don't have any feelings with regard to you having state-sponsored insurance. The thought is that having state-sponsored insurance makes life more stressful, and somehow that increases your risk for preeclampsia. And she decided that I was biased and left the clinic angry and decided that she didn't want to see me any longer. Several weeks later, she sent me a message through my chart asking if she could come back because she wanted a female provider and she recognized that I wasn't mistreating her. So we had to send it through the compliance, and they said no. So patients can have misperceptions for a lot of different reasons, and it takes a lot to navigate through those sometimes. But just recognizing that it's not personal and that it's okay for her to feel that way, that it's not personal, and you can try and address it. And if she is insisting that that's how she feels, it's an okay thing. But at least try and help her work through it is the only point. Next slide. So the key takeaways across the articles are that stigma and punitive responses undermine care. Patients who use substances during pregnancy, especially women of color, often face judgment, surveillance, and threats of CPS involvement, even when seeking care voluntarily. And that is without question. It is across the board, whether I was doing my training at Cedars, working at DC General Hospital as a resident, and when I was at Howard, or working in inner city Baltimore, there is absolutely no question about the fact that women of color often face judgment and increased surveillance, and CPS is often used as the weapon against them. Bias and racism compound risk. Experiences of racism, gender bias, and stereotyping worsen fear and mistrust, contributing to delayed care, inadequate pain management, and increased likelihood of family separation, and increased likelihood of coming into care. So patients don't seek care because they're afraid of the judgment. They're afraid of not being trusted and being looked down upon. That is without question. Medical mistrust is rational and predictive. Group-based medical mistrust is strongly associated with care avoidance, anticipation of discrimination, and concerns about treatment outcomes shaped by real prior harms. So we can't minimize that fact. And talking about them and being open about them gets us a lot farther down the road than you would think. Fear limits disclosure and engagement. Patients often withhold information about substance use because of anticipated punishment, not lack of interest in health, and that reduces opportunities for support and safety. Support resources are insufficient. Participants reported inadequate access to non-punitive, culturally responsive support for pain management, withdrawal, and emotional needs. Clinical opportunities, mistrust and trauma-informed care, non-judgmental, evidence-based care, including harm reduction strategies and shared decision-making, may improve engagement, strengthen trust, and reduce maternal infant harm. Stigma and systemic inequities shape both patient experiences and learner discomfort. Evidence can help anchor empathy and critical reflection.
If I could jump in for just 1 minute. I just got back from Learn, Serve, Lead,
Of course.
AMC conference, where mistrust was a very big topic being discussed. And I was struck by the fact that a lot of people were like, what's wrong with these people? Why don't they trust us? And there were some people who said, some people have very valid reasons for being
Right,
mistrustful based on their experiences and some of the history that we know all too well. So I just thought
right.
that was interesting, as they kind of said the same thing in these three articles.
Yeah.
Anyway, sorry, I didn't mean to interrupt.
No, and it's very true. It's very true. I am one of my favorite patients when I was in Baltimore was a young woman who was 16 years old and HIV positive. She was infected by her 19-year-old boyfriend. Her mother was married to a man who had a history of IV drug abuse and was also HIV positive. And the system at Hopkins, which of course represented the ivory tower, had accused the stepfather of molesting Renee and insisted that that's how she was infected. And that created a very negative situation in her home life. So her mother was very anti-Hopkins, and didn't want Renee to come there for her prenatal care, and was very, very, very angry. But Renee needed specialized prenatal care so that we could reduce the likelihood of her baby being born positive. And it created a lot of conflict. And so it was difficult for me because even though I was a Black woman, I still represented the enemy. And Renee's membranes ruptured prematurely, and that increased the risk of her developing chorioamnionitis, which was going to increase the risk of the baby being born positive, even though her viral load was non-detectable. And so the mother had not shown up for any of the prenatal visits. And remember, Renee is only 16. And so I had done all of the prenatal visits and had tried to shepherd Renee through all of her prenatal care and had kept her viral load down. The mother was angry on labor and delivery because she didn't want to be at Hopkins and she was mean towards the residents. And so they had called me out of clinic after her membranes had been ruptured for more than 12 hours and she wasn't progressing in labor. And I'm like, okay, so Renee, you need to have a C-section before your temperature spikes, and that increases the risk of the baby being positive. And the mother's like, no, she's not having a C-section. This is my baby. And it was just a real struggle. So there are real issues that have to be addressed, and they have to be addressed with care, because there is a lot of mistrust, and it's going to take a lot to break through that. So this is where I'm sorry, next slide.
Mhm.
So this is where marijuana is currently legal. The green is where marijuana is legal for adult use currently, since 2024 in the United States. The darker orange is where it is illegal, and the lighter orange is illegal, except for small amounts. The pluses are where you can have legal for medicine for medical use, and the purple pluses, you can have small amounts of marijuana for medical use only. So this is a dramatic change even from 2017. So marijuana is readily accessible across the country without any question. And it's important to remind patients that legal doesn't mean safe. So when I have a patient coming in for a prenatal visit and she looks at me and rolls her eyes and says, well, but marijuana is legal, I have to remind her that alcohol is legal also. But just because it's legal doesn't mean that it's safe for the baby. And then the light turns on. So she's not doing it because she thinks it's safe. I mean, it doesn't occur to her that it's not safe for the baby. So fetal alcohol, the prohibition ended in the United States in 1933. Fetal alcohol syndrome wasn't recognized until 1973. It took a whole 40 years before we realized that fetal alcohol syndrome was a thing. So there have been a lot of studies looking to see what are the consequences of marijuana use in pregnancy. And we've recognized that there are some problems. It doesn't look like it causes structural anomalies like fetal alcohol syndrome, but it definitely impacts fetal weight gain, or so those babies tend to be smaller. And there are some other issues that we'll talk about later. So next slide. Why do women use drugs during pregnancy? Age. So teens are more likely to abuse drugs during pregnancy compared to older women. Adolescents and young adults are biologically wired to take risks and experiment with tobacco, alcohol, prescription pills, and illicit drugs. Unplanned pregnancies. Approximately 45% of pregnancies in the United States are unintended. So women aren't using birth control consistently, and they are partying, so to speak, or living their lives, lifing, and using substances and get pregnant without recognizing that they're pregnant. Some women are using and have physical or psychological addiction, and they're unable to quit. And then there's an underestimation of the risk involved with the substances that they're using. Next slide. Women abuse drugs for some of the reasons that we talked about before. So, of course, marijuana is much more accessible than prescription strength antidepressants or antiemetics. So, there's been a history of medications that we thought were safe, think thalidomide. And so people don't trust the medical establishment. Again, they feel that marijuana is natural, that it's been around for centuries. And so they feel much more comfortable using marijuana, and they don't recognize that there are consequences. Next slide. And so prenatal cannabis use and maternal pregnancy outcomes. This is a study that was just recently published in the last edition of the Green Journal, I think. And it showed that women who use marijuana have an increased risk for gestational hypertension and preeclampsia, and that sometimes they gain more weight than is recommended, and sometimes they gain less weight than is recommended. So we're still working some of this out. In terms of fetal outcomes, there's no question that THC crosses the placenta. Babies who are exposed have a smaller head circumference. They have poor executive functioning as they enter school. They have problems with memory. They're more likely to have ADHD and behavioral problems. And so sometimes I tell patients, patients who complain that they are having problems with depression and that they're using marijuana as a consequence, of their depression, or because a consequence of their problems with hyperemesis, that if you think you're having problems with depression, have a kid who has behavioral problems. You will definitely have problems with depression. I mean, so I kind of say that, tongue in cheek, but it's real. So, you're compounding your problems potentially rather than solving them, and thinking about that and recognizing that that we do have a lot of options in terms of antidepressants that can be used and other ways that we can manage depression rather than using something like marijuana where we know that it compounds the issues for them. And then I think it's now your turn, Rosemary.
Yes, I'm going to jump back in and thank you. That was really interesting. So, we're going to talk a little bit about the teaching of this. When we teach topics like substance use disorder, trauma, suicide, the content itself is inherently charged emotionally, as we've discussed. But equally important is the emotional response, both from the learners and from ourselves as educators. We're emotional beings too. And that emotional layer can influence how learners process and integrate information. So, if you're feeling really awkward around it, they're picking up on that. Someone may respond strongly because of a personal history, a recent patient experience, or uncertainty about how to feel. And these emotional layers aren't necessarily obstacles to learning. They're diagnostic clues about how learning is occurring. So some of the impacts we can see, we know from cognitive psychology that emotional activation actually influences attention and memory and retention of content. When emotion is high, and negative, such as fear, shame, guilt, our ability to learn narrows, it becomes less. For some people, that means disengaging or becoming defensive, where others may overpersonalize or struggle to stay present in the learning because they're reliving traumas. So if a learner appears like they're checked out or they're getting defensive or argumentative, it may reflect emotional overwhelm rather than disinterest or lack of knowledge in the subject. So we have to be sensitive to what's happening there. I have one personal story to share. I'm telling on my husband, who's a standardized patient, was doing a simple OSCE or simple training around motivational interviewing. It didn't seem all that complex, and most of the students went through it, no problem. And it was somebody who was having difficulty giving up smoking. But he had one student who became extremely emotional and had to leave the room, and then later learned that that student had just lost a family member who couldn't quit smoking and died of cancer. So we don't always know what's in our learners' history that may be triggering for them around some of these difficult topics. And faculty are also not immune to we hold our own biases and our own emotional reactions. Frustration about care gaps and lack of equity and disparities in healthcare. We may feel empathetic and we may have moral distress about choices that patients are making, and the learners can pick up on your distress. So, discussing harm reduction or relapse can often elicit strong feelings, especially when the clinical realities can conflict with your personal beliefs as a clinician. So, there can be a lot of emotionally charged uh, things going on in your teaching of substance use disorder, not just in your care of patients. So there are some ways of addressing this. We want to treat emotion in the learning environment as data that we're exploring, not that it's a disruption to learning, that it's part of learning. And when a strong emotion shows up, instead of seeing that as a distraction, we can use it as a teaching opportunity. So we need to acknowledge the emotion and then help learners try and make meaning out of their emotional responses to that content. So we can use certain kinds of structures to help learners stay focused and feel psychologically safe. So here are just some examples. I notice there's maybe a little tension here. What's coming up for you is a good question to ask a learner that you sense is having an emotional response. Or it sounds like this topic is bringing up some frustration for you. Can we talk about that? Can you share with me why you're feeling that way? Naming emotion also helps normalize it and it frees up cognitive space for learning. So, oh, Dr. Kendrick, please jump in. I see you have a hand up.
Yes, thank you. So, very good comments. And I have a question for you that hopefully you can elaborate a little further on. So let's say the scenario is that you have a student that, may have had traumatic past in the background. They've heard a lot because of our political landscape, and they've already made their political, they've put their flag in the ground about where they stand politically. And it's not necessarily the same kind of scenario that we have, but this scenario is now more so about what the literature says and the research says. And you see that the learner is so emotionally charged about politics that they can't get into patient care. And you're concerned that the emotional, and I like what Dr. Ross said, because Dr. Ross said that it's like she didn't deal with the issue, all the personal emotion. She just dealt with the patient, what's going on. how do you get the students that are already emotionally charged? And I'm saying this because I'm starting to see this now,
Hmm.
and it's new for me, and I'm not sure how this works. How do you get the learner to understand the impact that their own then bias may have on not just patient care, but even their own success in being able to matriculate through medical school, residency, and those kind of things?
So let me ask, is this something that someone has sort of, I liked your metaphor of planted a flag in an area that's counter to what we know in the literature?
It's not necessarily that it's what we know in the literature, but it's like, when does what we know in the literature now make you so emotionally charged? Like, yes, we know that people get mistreated. And I gave them some scenarios, for instance. Oh, I just said, so it's obviously happened. So I gave them some scenarios for when I trained, okay? And I gave two scenarios. One was a scenario with a person that came in with a swastika, trauma patient, operated on them. And now, guess what? The swastika had trauma to it. And now I've got to sew the skin. What do I do? Do I
Hmm.
sew it? Do I not sew it? Do I sew it in a way that's twisted? These are the kind of things that come up. Another patient came in with a gunshot wound to the head. Do you take care of the patient? But now you found out that the patient actually is here because he shot himself in the head after killing his wife and his children. And so these are the kind of scenarios that I gave the student, because I'm just like, I understand where you are, but getting to your point, I'm still not that happy with sort of just giving scenarios and saying, hey, I think, you know, I understand where you are, but I think part of it is, even if you know the system has bias in it, the question is, how do you get to the point that you can improve the system without impacting negatively patient care? And so I'm not really sure if I gave a good answer, but so this fits right in what you're saying.
Yeah, and I mean, it's incredibly complex. I mean, the scenarios that you're talking about obviously are extremely emotionally charged. I mean, you would have to not be a person to not have emotions come up around topics of this nature. So that's one of the first things I would say, is that you just have to acknowledge that this is difficult, and it's difficult emotionally for a lot of reasons. But I think, centering on patient care would still be, I think, important. Dr. Porsche, really great questions. When do you draw the line, and can you draw the line? I'd be interested to hear what others think about this. Like Dr. Fortuna, do you have a response to this?
In terms of drawing the line or just the whole,
Or how you address the line if the emotions are now making it, or someone has gotten to a point where their emotions are interfering with patient care, interfering with their learning, and might actually impact their ability to matriculate.
I mean, I think, we've been talking about two different things related, but related, right? So one is in the clinical moment, right, where all these emotions occur and we have to do something, right, for the patient. We have to sew up the skin that has the swastika, you know what I mean? Like we have to do it, right? And in some ways, the thing to do there is how to sort of calm things down and the emotions enough so that we can do the work of operating, of healing, of what we need to do in that moment. And then I would feel like outside of the immediate clinical scenario, we got to do some work, right? Like, sort of do the stuff that Rosemary is saying. Let's talk about what happened there, right? Let's validate. I get it. I didn't like to see that swastika either, right? Like, how do we manage those things, right? And, to be physicians, right? Like, what are the kinds of things we can do for ourselves? Because there's always going to be these there's always been tough situations, right? in substance, it's all, in the HIV crisis, right? People are like, well, why are they like shooting up? Like, don't they know? You know what I mean? And why should I take care of people when they're doing these things? And I think we have to have some space to be able to have some reflections about that with learners, right? Like, it's always the elephant in the room. Let's put it in, let's look at it and let's figure out how do we manage through it, right? If we're going to take care of it, anyone who comes here, right? Like we have to take care of them. How do we take care of ourselves in these like really challenging scenarios and encounters? Because we have to be able to do that, right? And building that space to build some self-regulate, emotional regulation, resiliency, ability to manage this so that I can still learn, I can still be a doctor and face these situations so that maybe the next time we encounter them, we've had some time to process and prepare to do that together. I don't know. I see
Dr.
Dr. Ross has her hand.
Yeah,
Yeah.
Dr. Ross has her hand up.
I think you're absolutely right that we deal with this with the immediate situation at hand. So you address the patient's immediate need. They're bleeding, you have to stop the bleeding. And then you take it to the ethics committee. So, again, in Baltimore, we had a situation where a woman who was HIV infected married a man who didn't know she was positive. She was pregnant. It wasn't his child. He knew it wasn't his child, but he didn't know she was positive. And so she told us that he married her knowing that it wasn't his baby, but not knowing she was positive. And so we weren't sure what our responsibility was, in the prenatal clinic. And so we took it to the ethics committee. Our concern was if we disclosed to him that she was positive, would she stop coming in for prenatal care? And if she stopped coming in for prenatal care, would her viral load go up? And would that then mean that the baby was at risk for being infected? And so with the ethics committee, what do you think they said that we needed to do? They said, of course, we can't disclose until after the baby is born. That, our first responsibility was to the fetus, and that, we after the baby was born, we needed to keep her viral load down. And after the baby was born, we could tell him she was positive. And that was how that was handled. And so getting more minds involved who aren't necessarily invested at that point, at that moment, helped us to figure out what made sense, and so that's how we had to handle it.
And I think that the question that Dr. Kendrick added into the chat is interesting as well. How do you teach students where to draw that line? The political beliefs are supercharged, and that's a concern that I'm seeing. So I think, yeah, the needs that is part of the role, right, is to teach them where that line is and how you prioritize care and then unpack what's happening after the
Let's
fact,
first do no harm. So they're
right?
they're physicians first. So, and they made a commitment to be physicians first. So their first priority is to address the patient's medical needs, and then they can come back and do the other work,
The other work. And
Yeah.
I think there's, supports also that we have to advise students of. And that may be I think Dr. Porsch made a good point in the chat as well on that. Uh, the really good conversation and very, very interesting issues to address. So again, just talking a little bit more about some of these strategies. So, modeling is trauma-informed care is a really great teaching tool as well. So replacing any deficit focused questions with supportive inquiry. So instead of why did you use, what helped you? What helps you cope? What made it hard to talk to your provider in the past? To clarify mandatory reporting policies and be very transparent. And that's something I would say in any teaching scenario is that, as educators, we are mandated reporters. And so if a student is about to disclose something that you have to report, you need to be very transparent. And you also, of course, need to be transparent with patients and model that for students of where that line is. Uh, reinforce language of dignity and agency. So, person who use substances rather than an addict or abuser, using, language that is non-judgmental. Recognizing substance use as a health condition and not a moral failing, I think, is an important aspect of that as well. And reinforcing that message in your teaching and in the way you role model that during patient care. So some, again, really practical strategies around this is to slow down. It's our nature when things get uncomfortable. We tend to, our adrenaline starts pumping and we want to speed up and get through it because it's uncomfortable. Try not to rush through discomfort, but try do the opposite, taking a breath, stepping back, slowing down. Acknowledge the emotion without judgment. And that's sometimes hard because we're people too. But that's where, we have to kind of take that breath and ask reflective questions instead of countering their statements. So, that's interesting. What led you to that? Why did you go there? Why are you having that reaction? Rather than, that's not okay. Recenter on the values that are shared values for healers, empathy, professionalism, patient-centered care, keeping that center and front, that should be the North Star for students. And again, I think that also applies to this discussion around where that political line is. The North Star needs to be patient care, right? And use structure so that the students don't feel lost. So, if you're using, say, for example, to step back from something as emotionally charged, but if you're using a case scenario like the one we talked about earlier with Jasmine, what assumptions might be influencing how we're interpreting this scenario? That keeps the discussion educational rather than reactive and triggering. So again, support the learners through that ethical and emotional complexity by normalizing moral distress and uncertainty. I loved what Dr. Fortuna said. Yeah, I didn't like that either, right? We can share some of those strong emotions with our learners, offering psychological safety that helps learners make meaning out of discomfort without feeling shamed around it. Debriefing challenging cases together, focus on what systems failed and not who failed. I think that's an important one. What about this? What about the system failed rather than the individual failed? Model, and I was again going back to all the conversation I heard at Learn Serve Lead about why do these people mistrust us? And a lot of it, of course, is around measles outbreaks and that vaccine hesitancy. And I think that it's, again, we need to maybe reframe the question of what are we doing that's causing people to mistrust us more than why are these people so mistrustful when we have all these great facts, we know these things are good. That I think we're not always looking at it from that other point of view. So that's a good conversation to have with learners too, rather than, why are patients so ridiculous and they aren't following the science? Why is it that what are we doing that's making them feel distrustful of us? Model compassionate accountability. So learn to repair, not retreat after mistakes, I think is also important. Is that, that's something that I think is always hard for people to remember in medical education, where the stakes are so high, but you cannot learn without making mistakes. You cannot learn without stumbling. So just normalizing that, I think, is also really important. And now I'm gonna turn it back over to Dr. Ross for the next segment.
Very good. Welcome back to the OB clinical side of things, guys. Okay, next slide, Rosemary. So there was a survey that talked to obstetricians about their attitudes regarding marijuana use in pregnancy. And obstetricians are like, we don't know. Like, what am I supposed to say? I don't know. I mean, some of them were very honest about it, and they said that there just really wasn't enough data. That essentially what they told patients was that using marijuana was better. So 51 providers were surveyed and a semi-structured interviews. They said that they weren't not familiar with identified risk in pregnancy, that basically they felt like it wasn't as dangerous as other drugs. They believed patients did not view marijuana as a drug, and most of them focused on the fact that if the baby screened positive, the CPS was going to get involved. And one of the things that I have to say is that you have to remember that obstetricians are a very nervous bunch. I mean, we've been sued a lot, right? So I think that a lot of this drug screening culture for patients really came out of an era where obstetricians were being sued for a whole lot of stuff. And they were really just screening these babies because they were trying to say, it wasn't my fault. You know, it wasn't that they were pointing the fingers at the mother so much. They were just pointing the fingers away from themselves, I think was really what that was about. They were trying to figure out when these babies were born, like what else could cause this baby to have been born with a low APGAR score or born with respiratory depression. And so in addition to doing drug screens, for example, at Hopkins, they do a blood gas on every delivery, you know, because they want to know what the cord gas was every single time. Any place else that I did practice, whether it was Harvard, UCLA, whether it was Howard University Hospital, DC General Hospital, Cedars, nowhere else in the world that I practiced did that. So it's not just because we were pointing fingers at the patient, it was like trying to CYA. Okay, next slide. Now that I got that disclaimer done. So that's really what that was about. So what are some of the reasons for difficult conversations regarding SUD diagnoses? A long history of cultural, religious, and medical moral judgment of addiction. So if there's no question, we've kind of talked about that before. You know, people who don't measure up in our eyes as a society just don't measure up. I think we've gotten a lot better in general. I think we've begun to recognize and accept that that's just being overly judgmental is just not a good way of living. Relatively new medical understanding of neuropsychobiology of addiction has opened the door for medicalized treatment. And again, we're getting better with treating obesity. We're getting better with treating addiction of a lot of different types. High incidence of relapse can lead to feelings of ineffectiveness, not just from a clinician standpoint, but also from a patient standpoint. And whether we're talking about tobacco use or alcoholism or drug addiction, difficulty talking with family because of gray areas and mandated reporting when children are involved. Of course, we've kind of talked about that, and it brings up a topic that may strain doctor-patient relationship. You know, we want to be our patients' friends, so to speak. We want them to see us as their coaches and being on their side. So it makes it more challenging when they have to recognize that we have an obligation to report sometimes. Next slide. So talking about substance abuse in youth can be more challenging because, you know, of course, in that patient population, they're underage and it is illegal. And their frontal lobe is less well developed, and it makes it harder to talk to them about it because they're sometimes more resistant to change. And a lot of times it comes through or comes out of inequities and cultural trauma. So stigma creates barriers to care and discourages help seeking. Equitable care requires acknowledging systemic racism. Inclusive teaching reduces shame. And culturally responsive humility and family-centered approaches improve outcome. Next slide. Okay, so this one is a lot of unpacking, and we're going to break it down into two different parts. So this is about setting the stage before the actual teaching begins. It focuses on building a safe, supportive, and responsive environment. Strengthening trust and buy-in, learners are often more open when they feel respected and valued. Soliciting input and feedback, encouraging participation helps tailor the experience and makes learners feel heard. So we talked about patients feeling heard, so learners need to feel heard and appreciated also. Regular coaching or consultation, ongoing support reinforces learning and helps apply it in a real-world settings. And strategy for systems level change, aligning the learner with broader organizational or cultural shifts ensures sustainability. And what is it all about if it's not about sustainability, right? I mean, that's ultimately the point of teaching learners, to make it something that's sustainable. And then part two, structuring sessions to optimize learning and change. This part focuses on how to design each session to maximize input. Activating thinking, start by connecting to learners' prior knowledge and experiences, which again, of course, circles back to sustainability. Develop content knowledge, provide clear evidence-based information, offering practical strategies, share tools or techniques learners can use immediately, providing structured reflection activities, help learners process and personalize what they've learned, and translating into written goals, encourage learners to set achievable goals based on the session. Why does it matter? This approach is especially powerful in emotionally charged or stigmatized topics. It helps learners feel safe, engaged, and empowered to change, not just informed, which again, ultimately is our goal. I mean, that's what ultimately learning is about, feeling empowered to change. Thanks, Rosemary. Next slide. So emotionally resonant topics can trigger strong emotions, as Rosemary previously said. These topics often touch on personal experiences, either directly, examples are lived experiences with SUD, or indirectly through loved ones or professional exposure. As a result, learners may feel sadness, anger, shame, or discomfort, which can affect how they engage with the material. Like the example with Oski and the student who had recently lost a loved one from cancer. Strong emotions can disrupt preparedness. Intense feelings may interfere with cognitive readiness, making it harder to absorb, reflect, or participate. This is especially true if learners feel defensive, overwhelmed, or vulnerable. Training can also bring relief. When done thoughtfully, training can validate experiences, reduce stigma, and offer tools for healing or advocacy. It can help learners process their positionality, how they identify and shape their perspective, and feel more empowered. Why this matters for facilitators: if you're leading sessions on these topics, it's important to anticipate emotional responses and normalize them, as previously said. Create safe, reflective spaces for learners to engage. Offer supportive structures like journaling. So you may even bring in some cheap, journals from the dollar store for students to actually have time to journal a little bit. Encourage peer discussion or coaching. Balance content delivery with emotional processing. Next slide. So we're very familiar with OSCEs, so that can be a source of emotional uncertainty for students. Students may feel conflicted. They want to be a supportive peer, but they are also being assessed, which can push them to rush through sensitive topics. This tension can lead to emotional discomfort, especially when the stakes feel high and the subject matter is serious. Emotional display rules in medicine. These are unspoken norms about what emotions are considered professional, being calm and composed, and which are not, visibly upset or overly empathetic. These rules can make students feel unsure about how much emotion is appropriate, especially when they genuinely care or feel affected. Reflection can be used as a tool for growth. Many students find these moments thought-provoking and enlightening. They realize how much patient experiences and identities shape care. Integrating structured reflection, Again, journaling or debriefing helps learners process these moments and build empathy and clinical maturity. Why does it matter? This highlights the need for emotionally intelligent training. Oh boy, that's hard to teach. Not just technical skill building, it encourages educators to normalize emotional reactions to clinical learning, create space for reflection and discussion, teach students how to balance professionalism with authentic empathy. Next slide. And I think we're back to you, Rosemary.
We are indeed. And I'm going to go through these frameworks very quickly. We will make the slides available because we have some other content and we're getting a little short on time. But I did want to mention that there are several frameworks around this that can be helpful. So one is this framework for reproductive justice. And it's about, human rights and reproductive rights and social justice. It emphasizes collective well-being and challenges power systems, such as white supremacy, patriarchy, capitalism, that contain reproductive autonomy. So the foundational ideas here are pretty simple. The right to have a child under one's chosen circumstances, the right to not have a child, including access to contraception and abortion, the right to parent children in a safe and healthy environment. So I'm not going to read through all the core principles, but it is available, will be available to you on the slides if you're interested. Another model framework is the PREPARE model, which offers this structured approach for facilitating these conversations around sensitive and emotionally charged topics. And you can use this before, during, or after discussions about substance use disorder, trauma, adverse patient outcomes, or identity-related content, or, politically charged content. The model highlights both cognitive planning and emotional processing, supporting some psychological safety for learners. So really, it's just an acronym. Planning before engaging learners, clearly outlining your goals, reflecting on your own biases, your own emotional triggers and assumptions. And an example of that might be before discussing opioid use disorder, you notice you have strong feelings due to a family experience with addiction. So you need to plan how to manage, how to maintain your boundaries and avoid projecting your own emotions onto the learners. And the E is engage, so opening the session by engaging learners in co-creating norms is always helpful when dealing with controversial or highly sensitive material. So you can ask them, what do they feel safe discussing? Encouraging active listening and approaching with curiosity. And engaging, establishing, again, how do we establish psychological safety? We want brave spaces where people feel free to speak up, but we also want safe spaces so that they don't feel like they're going to be judged if they do. And then presenting, sharing the content clearly and compassionately, and avoid sensationalizing any of these issues, using narrative cases and things of that nature, keeping that, again, that something Dr. Ross just talked about, the emotional and the cognitive load balance. So pacing the discussion to allow for emotional processing. So an example of that might be you present a patient case involving overdose and recovering and describe clinical events factually rather than dramatizing it. So the A is acknowledge, name, and normalize, as we've talked about. An example of that might be a learner expresses some sadness that the patient has relapsed. So you validate their feelings and you ask what insights that provides them about patient care or their identity or health systems and barriers or whatever your learning goals are. Then revisit, check in with them after presenting the content, invite questions, invite processing, and helps move from the emotional reaction onto meaning making. Then the finally is for evaluate. Evaluate both the learning outcomes and the emotional impact. Ask yourself what worked well, what could be improved upon for future sessions. reinforcing that sensitive topics benefit from ongoing refinement and responsiveness. So we also need to give ourselves a break about what worked, what didn't work, and allow ourselves some space to learn and improve. Another framework for this work is the LEAP model, which is just very simple: listen, empathize, agree, and partner. Again, I'm not going to go into too much detail on some of these because of our time. And ORID is just a simple high yield. It's a great structure for case-based teaching when emotions are running high. So what facts do we have? The objective. What reflective? What reactions or feelings emerge? What is interpretive? What does all that mean in terms of the teaching moment or the patient care? What's decisional? What do we have to do next? And how do we move forward? So these different frameworks can fit different parts of SUD educations. Prepare sort of creates that intentional structure before, during, and after discussions. LEAP helps faculty respond to learner biases and defensiveness, and ORID balances processing with meaning making. So they all have a role and they can all be useful. And we have some case studies. If we have time, we'll come back to them. But I also want to just jump ahead a little and get to the trust building models that Dr. Ross is going to share with you before we
So
wrap.
these trust building models primarily are designed around community health workers and peer programs. And as Rosemary stated, you'll have the slides available. These are a variety of different models that are built around a variety of different programs. So the Dulce program is primarily built on helping patients better manage their diabetes, which is huge. As you all know, that the incidence and prevalence of diabetes is increasing rapidly. This program is designed to meet the needs of culturally diverse populations and is offered in a variety of languages, including Spanish. It uses a low-cost, sustainable model with trained community healthcare workers who conduct diabetes education classes in community settings. They have evidence-based results. The studies have shown that Dulce is effective in improving clinical outcomes for people with diabetes, such as reducing blood sugar and hemoglobin A1C and cholesterol levels, which is huge. And it's a family-driven approach. It's recognized and can be replicated. It's recognized by the American Diabetes Association and Medicare. Project Nurture is primarily focused on integrated OB and substance use disorders care with peer mentors. The DON program is peer support led by lived experience specialists, and it builds trust via cultural alignment and continuity. Next slide. There's Project Respect, Charm. UCSF has a program, Embrace, which is culturally responsive care for Black birthing people. And so there are a variety of programs. Next slide. And then there's a doula program. I'm going to say that one of the things that I had personal experience with was a HALO program in Baltimore, and it was a community care worker program of women who were HIV infected who went out into the community and identified other women who were HIV infected and were pregnant. So they brought those women into Hopkins and helped to make sure that they stayed on their antiretrovirals. They offered them support in a variety of different ways. And I think it was the community healthcare workers who really made the difference. And so there is no question that having peers makes a huge difference. So they made themselves available 24 hours a day, 7 days a week. They were friends first, healthcare workers second. When a patient comes in for prenatal care and she finds out that she's positive and, like, why me? How does this happen to me? I'm too young for this to happen to me. I only went to a tattoo party. How did this happen? I I've only had one partner, or I knew my husband was messing around, but I didn't know this could happen. All of those kinds of questions, and being able to have those conversations with women who looked like you, women who lived down the street from you, women whose kids played at the same park that your kids played at, just made a huge difference in all the world. And so having people from the community that patients could identify with makes a huge difference. So when we talk about mistrust for healthcare providers, having community healthcare workers bridge that gap is huge. And I think just looking at the number of programs, you can go through the slides, Rosemary, and just slowly to demonstrate the numbers of different programs that are out there and that are making a huge difference. You can see that there are a variety of programs and that they make a significant difference in our communities. And so with that, my slides are done.
Okay. So just some strategies around these. I think again, are many of these things we've already touched on. So peer culturally, you know, confident care, transparency, harm reduction, shared decision making. So the key takeaways here is structure helps contain emotional intensity, and reflection and interpretation deepens learning. So, modeling empathy reduces stigma. And we didn't address this directly, but we know from education research, stepping away from substance abuse into the education realm again for a minute, we know from education research that emotions actually benefit learning if they're addressed in the right way. Toxic emotions don't benefit learning. So that actually harms learning and creates defensiveness in our learners. But engaging emotions and engaging them in discussion around those emotions actually benefits their learning. So rather than feeling overwhelmed, they are processing. And I think that's a key takeaway here. So we wanted to just give a final reflective prompt before we close and open up for questions. And that was just if people want to share what you learned about yourself today in regards to this topic. So anyone like to weigh in on that? You can put your answer in the chat, or you can just unmute and respond. Happy to hear from anyone. Please don't break my heart and say you didn't learn anything today.
I want to say, number one, I just appreciated so much about these examples and really having the time to go slow and think about them. But I think it just reinforced for me how difficult it is when it's experienced near, right? So even thinking about the story of Jasmine, it's my feelings about thinking about my concerns about the child's, because it has reflection for my own uh experience as an adopted parent. So these things can get in the way. And my takeaway is that because these lessons are so emotionally charged, I need to have those lessons over and over again. And that's probably going to be the case with learners as well. You're not going to get it in the first one and only time.
Right.
Yeah.
And learning's a lifelong process, so it's always going to be that way. Did someone else started to say something and I think I interrupted? No? Okay.
I'll just add to that, I've implemented some of these practices, but I do think that what Dr. Kendrick was sort of sharing, that there are these very intense, polarizing moments that I think we're facing in a heightened way. And it brings to mind my sort of self-awareness of having to manage that with some compassion for learners too.
Mhm.
Because even though I try to model how we still taking care of the patients, and I'm pretty good at that, And I'm not so bad at maybe sort of doing some debriefing, but I may have to have a little bit more patience of what learners are struggling with.
Yeah.
You know, I think it's very intensified right now.
Yeah.
I think I'm sorry, I think for me, it just opened up a lot more questions because I'm thinking about the students and some of the transitions that we see just because of the culture shift. I'm thinking about the patients who have their own issues that they come to the system with, but also at the same time, if they interact with people that have the same different culture shifts. So for me, it's so new because I haven't had to experience this part of it before. Like I've dealt with patients that may not have wanted me in the room, but it was my mission to be there and make sure I provided care so they could see what that was like if they've never experienced that before. But I think now it's in a teacher learner patient provider relationship, it just creates a very it's a challenge for me to sort of figure out how to make sides meet when each one of them could be off kilter. It's almost like being a referee in a match and you don't know which one could, overpower the other. So I think but I think I really appreciate what you talked about, Rosemary, which is just really taking a deep dive into understanding this, being able to maybe someone said maybe you don't fix it the first time, but maybe over the course of time, maybe you'll see a change year 2 or 3, or,
Mhm.
maybe something to stick with them and that it clicks later.
All right. Thank you. Thank you all for sharing those insights. Great. I just have a couple more things to say before we call it a day. One is, we've got other programs coming up. On the 4th of December, we will be we'll have a guest speaker talking about emotional well-being for healthcare professionals as part of our Culture and Academic Medicine series. And then our next session for this program will be on January 14th, and that will be Teaching That Resonates, Designing Engaging SUD Care Sessions for Medical Education. I also want to point out that if you're interested, the Teaching Excellence Academy is a flagship program of the Office of Faculty Development. It's a competitive program, and it is a small group of community of practice approach. So I don't want to go into take up too much of your time talking about it, but if you're interested, just reach out. I'm happy to send you more information. I also just want to point out that Jose put in the chat this post event survey. And we're really asking you to please take a moment. I know everybody always asks you to fill out a survey, but this is part of the grant and the research that we're doing. So we really do appreciate, and not only that, we really deeply want to know your feedback. So there's a link and there's a QR code for that. And our time is up. And before we end, I just also want to say thank you so much to Dr. Ross for an outstanding addition to this presentation, and also to thank all of you for taking your time to join us. This was a very engaging session. I feel like I learned as much from all of you as you may or may not have learned from me. So I'm going to turn off the share. We have some references because I'm willing to stay on if people have other questions. And if not, I wish you a wonderful evening, and please enjoy.
Yes, and I just want to really thank you for doing that survey and the QR code. That is one of the things that SAMHSA wants to see that we are collecting. That's our funding for the expansion of our wonderful substance use disorder thread at the School of Medicine. So I just want to thank you ahead of time for filling that out.
Yes.
And Rosemary, when you send out the slides, it will include the speaker notes because I think there's a lot of useful information in the notes for some of the slides that I did.
We
I
normally
don't know.
don't include speaker notes, but
Okay.
we certainly can if people want that.
Yeah, I don't know. A couple of the slides, a couple of Michelle's slides that I went over, I think I was able to, through AI, Michelle. was able to-
You know what I can do? I can
Michelle loves
also,
AI.
yeah, I can share the original article if people would like
Yeah.
that.
So, all right. Thanks. Good
Are there any other
This was
night,
really
everyone.
excellent. Thank you.
Uh-huh.
Any other questions or comments? Thank you again so much for everything,
Uh-huh.
for
Of
attending,
course.
for your presentation, for all the support around it, both from Nena and Jose. Really appreciate everyone's participation. Thank you so much. Good night,
Good night.
everyone.
Thank you.
Good
Good
night.
night.